much, Lauren. I'm really pleased to be here, and this has been a long time in the planning, so it's really lovely to have everyone here tonight. So thank you for joining. It's such a critically important part of what we can do to help the children that we look after. And before we start, I just really like to just mention the Sydney Institute for Women, Children and their Families, because they have been critical in being involved in collaborating with both the PHN, the Central and Eastern Sydney PHN, and the community health services of both the Sydney Local Health District and the South East Sydney Local Health District. And for those who don't know, the Institute was actually formed in late 2018 and has actually become a central hub for research, education and policy, and really brings together exceptional research and educational professionals within the LHD and its partners relating to women, children and their families' health and wellbeing. The Institute works to create and foster a supportive and collaborative multidisciplinary research environment and has a vision to maximise lifelong health and wellbeing for women, children and their families through research, education and innovation. The Institute's management structure comprises of a multidisciplinary senior staff within the local health district across community and hospital-based services. And further information on Institute's staffing and the Institute's objectives, governance, partners and collaborators can be found in the prospectus link that's on the screen now. If you're interested in contacting the Institute or how to become an Institute affiliate, please contact the Institute's email below or George, the Director. Dr. Natalie Ong, who is a developmental paediatrician, and she works in the Child Development Unit in the Children's Hospital in Westmead. And so Natalie is going to present to us on how we can make a difference actually in screening and picking up children so we can offer them the early intervention. So thank you very much, Natalie. And Natalie will be showing us a video, so we're going to be interacting. And again, we're going to be posting some of our observations in the chat there, and hopefully we can share some of those things together. Thank you, Natalie.
Thanks, Margot, for your introduction. I'm so glad Liz went first because she's actually laid the foundations for a lot of what I will say, and that will probably truncate some of my slides. But I'm hoping to make this a somewhat interactive session. So please feel free to put in your comments, ask questions, and there will be a video for you to view as well. So as Margot says, I work in the Child Development Unit, but one of my areas of interest is actually in the early identification of developmental issues from a population health perspective. I've delivered training to GPs for many years in various settings, and we've assisted the local health district to develop an e-learning program to upskill general practitioners to conduct health and developmental surveillance. So I'll be quite excited to show you about our e-learning program. Now, how has this come about? We have a challenge. As Liz mentioned, 1 in every 5 child has a developmental issue by the time they start school, and that the average age of diagnosis of autism is 4. Now, if you think about it, if that's the time that we actually commence intervention for the children, we've actually missed out on those critical years, the first 3 years of life. And what are the reasons? It's not really only due to the early drop-offs in the child's visit to the child and family health nurses and them not being able to cover the population. There are many other family, social, economic factors that have played a role. And most importantly, other service providers, primary health, early childhood providers have never really been co-opted in this surveillance strategy until very recently, where primary health networks and health pathways have been working and increasing their efforts in providing education, training, and support through the use of health pathways to encourage GPs to undertake well child checks. So to begin with, I thought we would cover 3 areas. So understand child development from a biological, ecological framework and appreciate critical time periods. Understand the use of the child personal health record and recommended tools for developmental screening and surveillance, and why eyeballing is actually not good enough. And how we can gain an appreciation of the child personal health record, what are the important elements in a child health check, and talk about the use of some common referral pathways referencing your own local health district health pathways. So I thought I'd start with two stories, and these are 2 real stories of kids who came about a year ago to our Child Development Unit for developmental assessment. The first is a 14-year-old girl with moderate intellectual disability. Her mother speaks limited English, actually hardly any English, and she's a covered lady. And Dad runs a small business. They recall that they were first concerned about T at the age of 24 months, where she actually presented with no speech. And they had brought her to see their local GP, who reassured them that nothing was wrong. And then they went away thinking, oh, okay, you know, maybe there will be some catch up. Then what happened was they realized that not only her speech was delayed, that she had an overall global developmental delay. She walked at 18 months. She had significant communication issues. And because they were so protective of her, understandably, they didn't let her go to preschool because they felt that she couldn't cope. And so she then enrolled in the local school and trundled around for a few years. And when she was about 10, the school counselor did an IQ test and found that she had moderate intellectual disability. And as the year passed, her behavioral concerns increased and escalated. She was still in nappies and had begun to refuse school. She began, then the family eventually found their way to a pediatrician who referred her to us, had linked her to the NDIS end of last year, so she was 13 then, began therapy in January earlier this year, and we diagnosed her with autism. Now, the biggest thing that struck me about this case is the family's lack of understanding about how to manage her at many levels, you know, how to manage her toileting, her communication, how to manage her behaviors, and the lack of understanding of autism and how it was affecting her abilities to grow and develop, and all these missed opportunities. As opposed to the second case, also another child who was referred to us. This time, well, we saw him when he was a lot earlier, at about the age of 3 or so. He had a history of speech and developmental delay at 18 months. And his issues were picked up by their local GP. And in fact, his mother was a GP trainee herself, subsequently referred to a pediatrician, and it commenced speech and occupational therapy early and intensely, and that the communication and socialization issues that he had already resolved so much by the time he came to see us. And I would have thought that we would have ticked all the boxes for him, but because he had made so much progress, we actually withheld the diagnosis, reviewed him over 12 months. And what happened was, in the subsequent year when we saw him, his therapist had already done a school readiness assessment and found that he was actually quite ready for school. We thought, okay, let's do a school observation for what it's worth. And we could see that he had some abilities for joint interaction, some solitary play, but he was actually talking to another boy and they were playing with a toy together. Teachers were not complaining of any problems. And then we thought, okay, let's see what happens when he starts school. Maybe that's where the wheels fall apart. So after he started school, reports that he had actually settled in quite well, had made some friendships. When we observed him on, you know, the latest review, he had good eye contact. His communication had improved heaps, and he was developing very nicely with his early literacy skills. But when they left the clinic, we could see a line of toys lined up in a straight line, but nevertheless, a boy who was actually functioning a whole lot better. And then when I reflect on these two cases, whilst there could be fundamental differences in the genetic and biological potential and makeup of these two children, one cannot help wondering what difference it would have made to T if she had been picked up earlier. So I won't dwell on this slide too long. Suffice to say, Liz has already covered it in such great depth, and I don't think I'll do it better justice. But I just wanted to draw your attention to my favorite Bronfenbrenner framework. I use it all the time because I feel that it's actually quite a good way to think about child development and behavior, and that the child sits in the middle of layers of influences that exert direct and indirect influences on the child, and that it's transactional, so that it's not just the environment acting on the child shaping their behavior. How the child then develops will then influence how the environment in turn exerts their influence. So it's transactional, and it occurs and evolves over time. So there's chronosystem effects as well. And then once again, the importance of the early years, the critical periods of development, that if we don't identify problems early enough and address them, we actually miss the opportunity for the child to achieve optimal outcomes in that area of development. Another graph that you may have seen is the return of investment graph. So what it's saying is that the brain's ability to change in response to experiences is far more sensitive because of the plasticity in the first few years of life. And the amount of effort this change requires is a lot easier, and it actually increases exponentially over time. Now, it's so important for us to understand then what is typical development. But because there's so many different ranges and things overlap, it can be quite difficult to know when something is falling into the impaired range, and that using informal milestones and clinical judgment can lead to inconsistent identification of developmental delay. So we'll pause that thought because I'll show you some research in this area. So to build on what Liz says, early intervention changes outcomes, and we have 50 years of this evidence from the 60s and 70s, preschool programs, abecedarian programs. There's so many programs of high quality early childhood education and preschool quality being associated not only with school age academic outcomes, as evidenced in the graph in the middle, but also in long-term outcomes. We're talking about job as prospects, income levels, adult well-being, all come from having a really good early childhood program, and having good early experiences actually influences adult outcomes at so many levels. And if you're interested, I have a collection of these papers I'm very happy to share with you. So that's kind of at a broad sort of population level, but what about individual therapies, like when you refer a child for Early Start Denver model, a very popular form of intervention for children with autism. Now, even for programs like these, it's known to demonstrate that these kids develop higher IQ, language, and socialization skills compared to community controls. And not only early intervention changes outcomes, but the earlier you start, the better the outcomes are. So that's the paper that's been produced by Doyle and Harmon. So we know that widening access to pre-primary education improves overall performance and equity. It reduces social economic disparities. And if you extend the coverage does not compromise quality. So now that we have all this body of evidence that early intervention works and changes outcomes and all that, how much of an impact is it actually making? The challenge is that despite all these benefits and promise of progress, a lot of this work is not equally distributed. That we're still actually experiencing a lot of these problems. Now, back in the 70s, the developmental pediatricians used to call it the new morbidity, that you're not so much seeing asthma or diabetes so much as you are seeing kids with behavioral issues or developmental issues. It's now evolved and it's called the millennial morbidity. And that Palfrey and colleagues in 2005 found that in spite a lot of these efforts of policy and program developers in enhancing early intervention and outcomes for our young children, we are still seeing increasing mental health concerns, the continued effect of socioeconomic, racial, and other factors leading to health disparities, the powerful effect of technology, screen time, all of our kids are hooked on it, and the emergence of the epidemic of obesity. And we look at Australia, the top 10 Australian childhood conditions also reflect this: screen time, obesity, lack of physical activity, drugs, internet safety, family and domestic violence, abuse and neglect, suicide. These problems have not been completely resolved. And that this is now the millennial morbidity that we're dealing with. So I'd like to share with you a survey that the Australian Paediatric Research Network had done a couple of years ago. And they've actually found that the proportion of developmental behavioral conditions that rose from 48% to 60%. More pediatricians reporting diagnosis of autism, attention deficit hyperactivity disorder, intellectual disability. Prescribing rates increased from 39 to 45% of consultations. So pediatricians in general are seeing more and more developmental behavioral conditions, and what more so in general practice. When we look at this population as a whole, the question of whether or not there are certain populations that are particularly vulnerable. So in the US, about 40% in disadvantaged group tend to miss developmental screening. And a lot of work done by Professor Valser-Epen in UNSW reflect that Australian results are quite similar, that there is an inverse relationship to social economic disadvantage to the likelihood of families being able to not only access health services, but actually participate in early childhood surveillance strategies. So this is a paper where they looked at what were the predictors of developmental surveillance completion at 6 months of age in southwestern Sydney. And they found that the families that were more likely to complete developmental screening were higher income, better informed, spoke English, had professional jobs, and those who were least likely to complete screeners were those of low socioeconomic status, linguistic diversity, gaps in knowledge as well. So then when we think about what are the core principles for improving outcomes for children, and the experts from the Harvard Center for the Developing Child tell us that there are three key things. If we want to improve outcomes for our children, what is it that we need to work on? Number one, support responsive relationships. So it's about fostering good attachment relationships for the child, not just with the primary caregiver, but across different contexts and with multiple attachment figures. Reduce sources of stress, not just for the child, but for the family. And Liz talked about, maternal antenatal sources of stress, because the stress acts on the efficacy of the ability to be able to develop good attachment relationships, and it also affects the child's ability to develop core life skills in their executive function, their planning, the ability to manage their emotions or feelings. So these are the three key things that interact with each other and areas that we'll need to address to improve outcomes so that our children, when they have healthy development and good educational achievement, become adults that are responsive and are caregiving and have economic stability. So how does this happen at the GP level? What can GPs do about it? A few suggestions. I suppose participating in developmental surveillance means that you can enhance access for families, for the children to have health and developmental surveillance and identify problems early. Recommend high quality early childhood services and therapies. And because you're in such a unique relationship with the families, you actually get to know them through the years, and you get to know all the various issues that affect the family and the children. You're in a very good position to make such a good, big difference to them. Provide good parent psychoeducation, not only about early childhood issues, but preventative health issues, where to get help and support for the needs of the whole family, not just the child. So why well child checks in primary health? It's a bit rhetoric. So we know that families see their GPs most often as their health provider, and this is the great opportunity to participate in this surveillance strategy. So all of you have seen this. This is our child personal health record, otherwise known as the Blue Book. It's a record and resource given to our families, our children between 0 to 5 years. Other states have different versions, and primarily the screenings and surveillance are done by our child and family nurses. And that it has a triple role in prevention, detection, and intervention. So the child personal health record is used to elicit and attend to parents' concerns about their child's development. It's a record, so you document, you maintain a record of the child's health, growth, and developmental history. It's a chance for you to make accurate observations of the child. So you're not just taking the history or eliciting info from the parent, you're also watching the child and observing and making accurate conclusions about what you're seeing. It's also used to identify risk and protective factors and provide anticipatory guidance, advice on all sorts of early childhood issues or things that parents come to you about their child. And to maintain an accurate record to document the process, findings for further assessment and interventions. So I won't go through this in great detail, but the latest version of the Child Personal Health Record includes things like 8 healthy habits, things that you can talk to parents about healthy habits. The 4-month section contains an immunization section. 6-month talks about dental health. So Lift the Lid program has BMI charts as a more accurate way of screening for obesity. And that at every age check, there is a developmental screen, topics of anticipatory guidance that you can go through with the families. And here, this leads to the e-learning program. So this is an e-learning program that I had developed with key stakeholders in child and family health, GP Synergy, practice nurses, and the Primary Health Network a number of years ago. And this is an e-learning program that is designed to upskill general practice, so not just GPs, but also practice nurses to develop skills, attain knowledge to conduct health and developmental surveillance. And that's the link to the website. The components of it. The first module is examination of the infant and the young child. So it's going through the focused physical examination through the different age checks, hearing, vision, and growth. Anticipatory guidance, so it lists the 11 top topics of discussion that you can undertake with the family. This ranges from sun safety, smoking, nutrition, sleeping and settling, so on and so forth. Then there's developmental surveillance. How do you actually use the Blue Book to screen for developmental issues, and putting it all together. So some evidence to why eyeballing is not enough. Eyeballing is like casting your eye on the child, so say, oh yeah, the child's fine, type of thing. But there is a lot of evidence to state that eyeballing is often quite inaccurate. And I remember one of the earliest papers I've come across by Frank Oberclade. They studied, and these are experienced pediatricians in a developmental behavior clinic, and asked them to eyeball a whole group of children. Then they did developmental assessments on the kids, and 30% of them missed developmental issues. So even in the best of hands, you can still miss cases. So here we come to our interactive part. What I'd like to do is play you a video, and if Lauren could play us the video. Please watch the interaction between the child and one of our members of staff, and enter in the chat box what you notice about her behavior, her communication, and her socialization skills.
Like, could we just take her down this afternoon? So that they'll just take her blood, and then if it comes back with results,
I will copy it to Dr. Garg, so it goes back to the doctor or myself. And if there are any abnormalities, we'll contact you with the result.
Alright, so someone will definitely call me when the results are ready. Okay. So should we be organising an appointment with Dr. Garg?
Yes, we would ordinarily say follow up with Dr. Garg, and he will get a copy of the report. Then he's basically your coordinator now. He's going to kind of help you with coordination and referrals and stuff. Because if something turns up in the sleep study or the sleep clinic again, there needs to be some follow-up, so he should be your main person.
Okay. Like, I know it's kind of a stuff in the dark, but like judging a higher possibility for a genetic component?
There is a possibility, especially if you have what we call dysmorphic facial features. There is a high possibility that could be related to that, but just looking at her, I don't think she has the distinct features of any such particular syndrome that I can pinpoint. So I think it's probably better to let the experts deal with it, because the geneticists are seeing kids all the time with these sorts of things. They will be able to tell you, oh, maybe she's some form of something. But you know what? A lot of times, from my experience, if you go to geneticists, they're like, interesting. This is our features, but you know, we can't place it on anything.
Okay.
But let's just keep an eye on things and that sort of scenario. But
We go here, so we'll take her for the blood test. So when do you reckon we should go back to Dr. Dart? Maybe in like 6 weeks or something?
yeah, his next available, because I imagine they're a bit of a wait for
Okay.
these clinics as well. I think give it at least 6 weeks so our full report is ready as well.
Okay.
Violet.
So for the genetic, I just take her for the blood test. I don't need to make an appointment with the genetic. Okay.
So the referral will come from me, so you will get a letter and a phone call hopefully advising you of the date of the clinic appointment.
Clinic appointment with the
Okay, so let's stop the video and let's see what our participants have to say about their observations.
Can you just give that?
Oh, thank you, Natalie. That was an interesting video to watch. We've had a couple of comments have come through, and I guess the first one of note was that noting how frustrated and angry she was getting and not wanting to be very cooperative in her play. She was very dominant. And I guess the second observation that's come through is about her language, which was very much to do with it was quite hard to understand her, really. There were quite short sentences and really just commands telling the other person what to do. The other one we've mentioned is that it was just really fleeting eye contact. There wasn't an awful lot of eye contact. She would look up, look at the person, but only when she was really telling them what to do.
Yeah.
And I think they're the main points. I mean, she was actually quite good at matching the colours, so putting the balls in the blue ball in the blue hole and
Very
sticking
good. I didn't think you would notice that. Excellent.
Yeah. Frustrated when the other person didn't do what she was supposed to do and put the ball in the right place. Yes, and
absolutely.
Yes, I think that was the main observation. So, what can you tell us, Natalie?
So to say that that was very, very good observation. So from watching, you can see that instantly that there is something unusual about the manner of this child, that she had a rather boisterous, bossy approach, and she was quite on her terms, wasn't she? And then the second one is the fact that her language, her articulation is not clear, but you could still make out a few words and phrases. It's basically just telling Diana, who's our OT, what she had done wrong and what she should do. So once again, quite on her own terms, and you can see this sort of difficulty with theory of mind. She's kind of like the my way or the highway type of child, and the need for exactness, isn't it? The green ball has to go in the green section, the blue section. So I'll just give you a little bit of context and background to her history. So she came to us for an assessment of her speech and her behaviors. Antenatally, nothing untoward apart from some reflux and nasal obstruction. She had T's and A's done at 2.5, but her parents found her tantrums very difficult to manage. She was very unpredictable. It would take an hour for her. Anything would trigger, a tantrum episode. They need to hold her very firmly to calm her. They brought her repeatedly to the GP and pediatrician, and both had reassured them that she was okay. Parents felt that her eye contact was good, but she was quite on her terms. But I agree with the comment that the eye contact was fleeting. And not only that, she didn't really use a lot of gestures with her eye contact, and they were not coordinated as well. Babbling at 8 months, 2-word phrases at 2 years seems okay-ish, but her articulation was very poor. And in fact, she'll use of some jargon in her speech as well. Parents felt that she could hold things up, point and vocalize, but often not fully directed at others. Repetitive phrases were used as well. And so Mum gave this story of how she had used the F word when she was at a car park one day, and V had heard it. Every time they go back to the car park, V will say the F word. Pretend play, she has some abilities to pretend play, but as you could see, very much on her terms, quite bossy, and she actually prefers solitary play. The other thing that didn't come through in the observation is the fact that she does not realize her strength, and that she would be quite rough with her mother, hugging her, hitting her, bumping up against her in a very forceful way, and laugh about it. She doesn't realize or read Mum's emotions or feelings, and she likes to spin herself and walk on tiptoes. So, well, what would happen in the general practice context? So say, for example, if V came to your rooms and you did a check, and we would use the 3-year check because that's the closest to her age. And this is what the Learn the Science Act Early page would look like. It has a checklist of key developmental milestones in the various areas: social, emotional, language, communication, and cognitive, motor, so on and so forth. And we will get Mum to fill it. This is just an example of the ASQ. So the Ages and Stages questionnaire in New South Wales is the secondary screener. And we can talk about when we would use a secondary screener. Now, the Learn the Science Act Early is the primary screener. It takes 5 to 10 minutes to complete. And there is also a parent app which tracks development of their child. And you can actually get them to download it from the CDC website. And it actually maps to the Learn the Science Act Early milestone checklist as well. With the Ages and Stages, it also takes about 10 to 15 minutes to complete. It tends to be done as a secondary screener. So if you're not very sure, you can actually use that as well. And I've inserted a link where you can actually access the Ages and Stages on a website for free, as well as the website where they actually sell the screener in paper form. So this is what Violet's mum completed in the Learn the Science Act Early, as well as the ASQ. And you can actually appreciate just in a gestalt, already there is so many gaps and areas in which she is not achieving in terms of her milestones. And you can see on the ASQ, she scores significant in the areas of communication, personal, social, borderline for fine motor, and okay for problem solving. One of the key things that came out in the language and communication section was that she was very much on her terms, and she will tell you what she wants. So that's how using a primary screener can actually give you, in a very short space of time, the red flags or the issues that the child may not be achieving given their age ability. So that comes to the next question. When would you do a secondary screen? So for example, like if you have an ASQ at hand and you've completed the Learn the Science Act early, when would you consider doing a secondary screen, and what sort of value will you achieve from it? So it's over to you, Margot, to collate any responses. Thank you.
I think that one of the things that's coming up is about coming from that first case study that you had, where the parents weren't very particularly health literate or empowered. And I guess there might be some parents who may not feel very confident filling in those reports, maybe the language issues, or just understand what that all means. So that was one of the things that was raised. And I guess when we ourselves are not as confident, when that might be some sort of a borderline situation where we're not really confident that which way to go and whether we should really be, we don't want to miss. Obviously, your two case studies, the first one was quite tragic when the GP missing, giving that opportunity to the children.
Yeah, you're quite right. I mean, particularly when you feel that parental history is not that reliable, you would do a secondary screen, absolutely. And also if one is not very sure, you're looking at the primary screen and you're like, not quite sure. Yeah, that would be classically when you do a secondary screen. So anything that would make you unsure of the validity of the primary screen should encourage you to do a secondary screen. Now, if you don't have access to a secondary screen, what else could you do? Think about other places or people whom you could potentially refer to.
I think that we're going to go on to that because obviously this is very focused on GPs and of course our GP team, so our practice nurses who can be incredibly valuable in doing a lot of this screening. And our next section is going to come on to what do we do, because there's an incredible role for the allied health practitioners who can help, and of course the early childhood nurses who are very skilled as well.
Absolutely. So then that moves to the next topic, because based on what you have described, or V from the video, not only there were concerns about her speech and her behavior, her social interaction, her eye contact, these are sort of red flags for autism. So what we would recommend is to also use an autism screener. So in the US, they would recommend it routinely done from 18 months onwards, and that there are many autism screeners, so I have listed them for you. A lot of them require purchasing, so you need to purchase the license. Some of them are play-based, so you need training in it, or some are parent-completed questionnaires. But I think that the top two most useful ones at present that are free, that you can actually download or fill in on live on the website, it gives you a result straight away, is the MChat for the younger kids, 18 to 30 months, and the Childhood Autism Spectrum Test, which is 4 to 11 years. So this just gives you an idea of what happens when you have put the MChat in on the live website. So it gives you a risk score. If the score is less than 2, the child has passed the MChat, you would just continue monitoring. If the child scores 3 to 7, they're considered at risk. And it is encouraged that you would use a follow-up scoring sheet. So you would re-administer it, asking for examples. And based on what the parents tell you, there is an algorithm that comes with the follow-up scoring sheet that gives you a pass-fail threshold. Now, if the child fails on 2 items, you will need to refer for further assessment. If the child scores 8 to 20, it's a straight fail, and so that's referral for further assessment straight away. So that's basically how it uses the MChat. It's very easy to use, takes about 5 or 10 minutes to complete. I'm just conscious of the time, but I just wanted to highlight some key developmental milestones from the ages of 6 months to 4 years, certain things that you may want to kind of have at hand when you're seeing young kids in your practice. And what are the red flags for autism that you will need to look out for? So now that developmental issues have been identified, what are the next steps? I thought I'll just show you the health pathways, both for Sydney Local Health District, and we have some snapshots of Southeastern Sydney Local Health District. You may already be familiar with these aspects of the health pathways, but this is just to let you know that there is a section on developmental concerns. So this is Sydney Local Health District. This is Southeastern Sydney, one on milestones. And I quite like this one because it actually frames the topics by presentation as opposed to diagnosis. So like if you have a child with behavior problems or developmental problems, this is what you would do and where to go. Then there is the one on autism spectrum disorder. It gives you lots of really useful tips of what to look out for, what to do, and where to refer. The Sydney Local Health District non-urgent community pediatric assessment. So they have a good community pediatric team that would do secondary tier pediatric assessments. ADHD in children and young adults. And this is the Southeastern Sydney equivalent of the ADHD pathway. Early childhood support requests. So don't forget the early childhood nurses are there to support you as well, particularly if you would like them to do secondary screening and refer on. Child and family community support for Southeastern Sydney. And the same for Sydney Local Health District. These are resources that you may want to tap into for parenting supports. So that's the end of my presentation, and the 3 take-home messages. Developmental problems are increasing, and we really need a responsive health and social system for good outcomes. And general practice and allied health early educators are really the frontliners to enable early intervention for our children, and that you can use the child personal health record and the associated tools to assist you in early identification of these issues. And don't forget to use your health pathways to guide your referral practices. So that's all I have to say. Thank you very much for your time and patience.
Thank you so much, Natalie. That was really, really helpful, because I think we need to know what we can do. So Elizabeth certainly motivated me, and now we know what our next role is. And I'd also like to say a big thank you as well, because all of these speeches and the talks that we're doing tonight, and a lot of people have contributed, because a lot of the health pathways that you've seen are actually all getting updated to make sure that we are exactly aligned with everything that's being said tonight. And I think you'll see over the next couple of weeks a whole lot of things being published, including things on ADHD, autism, developmental screening. So that's going to be sort of watch this space, and Southeast Sydney is also working on theirs as well. So thank you very much, and we'll let you know when some of the new health pathways come out. And as I said, that leads us on to what do we do if we pick up some children who have some issues? What's the next step? And of course, there's an incredibly important role for community paediatrics and the services that are out there. So that's where we're headed now. So we're going to hear from 3 different speakers now. So we're going to hear from Rachel Walker, who's the Acting Director from Child and Family Health Services from the Sydney Local Health District. We're also going to then hear from Amanda Webster, who's the Manager of Services Integration and Equity in Child, Youth and Family Services in South Eastern Sydney Local Health District. And then Mandeep Padam, who's the Director, Violence, Abuse and Neglect and Specialist Services in the Community Health of the Sydney Local Health District. So I'll leave it over to you 3. Thank you so much.
Thank you very much. Can I check that people are able to see my screen?
I can see it. Yes, thanks, Rachel.
Great, thank you. And I would just like to thank Elizabeth and Natalie as well for their excellent presentations. Their summary of the evidence and their case studies has presented a very convincing argument, I think, for all of us to understand the importance of working together and particularly supporting families and children in that first 2,000 days. And so leading on from what Natalie has just been talking about, I'm going to be just briefly overviewing some of the information regarding how to make a referral to Child and Family Health Services in Sydney Local Health District. I'm not going to go through in detail every single clinical service and its eligibility criteria. That information is available in the handout section of the Go-To webinar. But what I would like to bring your attention to is how to refer to the Child Health Information Link. And this is our centralised intake service for child and family in Sydney LHD. It's staffed by allied health intake officers, child and family health nurses and administration officers. It operates from Monday to Friday with a telephone contact number that's listed there for you. And I've also listed there as well the link to the website for CHILL. Just some general referral criteria for you to think about, and we will be hearing from my CESLA colleagues after this where they will highlight what some of those differences are between our LHDs. For Sydney Local Health District, our children and families must live or attend childcare or school within our boundaries. And on our Sydney Local Health District website, you can see the links of the suburbs that we service. Each of our clinical services has their own eligibility requirements, but for the most part, there's consistency in that we accept referrals for children aged 0 to 12. Our community paediatric services will see children up to the age of 16. And a GP referral is not required except for our community paediatricians. Anyone can actually refer to our services, but where it's not the parent or the legal guardian of the child, we just require that there's clear evidence that that person has given consent for the referral. And the outline of our services is again available on that website. And I guess similarly to many health services across the country this year, our modalities of care have changed significantly due to COVID-19. And so there has been some significant change in how Child and Family is delivering our services. We are still prioritising and delivering face-to-face appointments where they are clinically necessary, and we are maintaining that. But we've introduced significantly more telehealth and video conferencing for both individual and group appointments. So that would include our child and family health nurses who are now doing new parent groups by video conferencing and transition to solid groups. And our referral pathways and eligibility hasn't changed. I guess one point of difference of something that has changed that's quite significant for us this year is that for child and family, we've actually had to include additional services to support those families who are in special health accommodation quarantine, and those referrals are forwarded to us through RPA Virtual. And it's typically where families are requiring support around parenting, where there might be some complex developmental concerns or broader psychosocial support that's required. So due to time, I'm going to hand over to my CESLA colleagues. Again, I'd point you back to the handout that's available for you on the handout section of the Go-To webinar. And that outlines all of the allied health, the child and family health nursing and community paediatric services. It gives a general overview of the reasons for referral, and it also outlines a little bit more some of the exclusion criteria, which primarily is children where there is a known diagnosis of moderate to severe developmental delay or intellectual disability or physical disability, or where children perhaps are already accessing the ECEI pathway or NDIS. And so after my CESLA colleagues talk, and Mandeep also gives a brief overview about Chapter 16A and Child Wellbeing Unit, I'll come back and try and draw together some of those points in a case study for you.
Thanks, Rachel. Can you see my screen? Just checking.
Yes.
Yep. Okay, so I'm Amanda. I'm here representing Child, Youth and Family Services from South East Sydney Local Health District. I'm not going to repeat a lot of the same things that Rachel said, and the service system across both districts is similar. Child, Youth and Family in CESLED encompasses our child and family health nursing services, our paediatric allied health services, our community paediatric and developmental and disability services, child and family counselling, and our violence, abuse and neglect services. And the slide that you can see in front of you is just the front page of a handout which is available, which also covers the services available and how to refer in CESLED. Similar to Rachel, we also have a map. The link's been included. Our information and referral criteria for our services is available on our website. And we have, I guess, a very similar service system, but there are some exceptions in the way our clinical services are arranged in South East Sydney. One of the main key differences is that we have Sydney Children's Hospital network in the north of our district at Randwick, and they provide some of the services for families in the north of our LHD. Not all, so the information you've got on the handout tonight will clearly direct you as to where Sydney Children's Hospital do provide services and where South East Sydney do. That contributes to the fact that we don't have a centralised intake number, so it's not as easy to refer to our services, but the handout has all the information is available on our website, and the handout has all phone numbers for each of those services, whether they be at the Randwick end or the Sutherland and St George end of our district. And I think, as has already been mentioned, we're also still currently developing health pathways covering our child, youth and family services and developmental issues for children, and they're continuously being uploaded, but the PHN would update you on that. The rest of our information is available in the handout. And I'll hand back to Mandeep and Rachel to provide some information on child wellbeing and 16A and a case study which will reflect service responses across both districts. Thanks.
Good evening, everyone. I just wanted to just make sure that my screen is shared. Okay, just 1 second. So I wanted to bring to your attention some important resources and contacts for when you come across some vulnerable families where you might be worried about child protection or child wellbeing issues. There is a handout that's been attached to all the other resources that have been provided that go into further detail around these key points that I've got on this slide. So the Northern Sydney the New South Wales Health Child Wellbeing Unit can be accessed during business hours for advice and guidance in relation to child wellbeing and child protection concerns. So GPs are now able to call the Child Wellbeing Unit when you're concerned about a child or a young person or even an unborn baby, and you're wanting to get some advice about what steps to take next. And in particular, the Child Wellbeing Unit can assist you with determining whether or not a child protection report needs to be made to the Department of Communities and Justice Helpline, or previously known as the Child Protection Helpline or the FACS Helpline. So the Wellbeing Unit is staffed by professionals who can provide you in some instances with additional information in relation to families or inform you of other services that may be in contact with those families and help you determine what next steps to take. The Mandatory Reporter Guide is also a tool that you can use to help you make decisions when you're concerned about children and young people. The Mandatory Reporter Guide is made up of decision-making trees. It's a tool where you answer a number of questions, and it helps you then determine whether you need to make contact with the helpline or to contact the Child Wellbeing Unit instead. The Department of Communities and Justice Helpline is available to be contacted 24 hours a day, and that is when you need to make a child protection report. In some instances, you may not have enough information to help you decide what next steps to take, And Chapter 16A of the Children and Young Persons Care and Protection Act 1998 gives us information sharing provisions that can also be used by GPs. So Chapter 16A of the Care Act identifies prescribed bodies who are able to contact other prescribed bodies to ask for additional information to assist in making a decision about the welfare and the well-being of a child or young person. There were some changes, there have been some changes made over the last couple of years where additional prescribed bodies have been added to the list who are able to use Chapter 16A, and that now includes GPs. The spirit of Chapter 16A is to be collaborative in information sharing, and so it's really encouraged that it is used not only to access information from other services, but to also provide other services with information. And Chapter 16A outlines quite clearly how you can go about doing that. It also talks very clearly about confidentiality and explains that you don't need consent when using Chapter 16A to access or share information, which is quite important. My colleague Elizabeth Murphy mentioned the out-of-home care health pathway, and Natalie Ong mentioned the health pathways. And I haven't actually got it on this slide or on the resource that is attached to the handouts, but the health pathways that Natalie showed us actually also has a link to access information around the out-of-home care health pathway. So I do also encourage you to have a look at that if you do come across a child or a young person who is in out-of-home care and you're wondering what to do next in terms of referrals for health assessments. Thank you very much.
Well, thank you, everyone, and thank you, Mandeep, for that summary. So I'm just going to go through a brief case scenario to try and demonstrate how some of our service responses come together that reflects some of the information that Mandeep has just been talking about, and also reflects what some of the allied health and other health service responses might look like. So a 40-year-old mother presented to her local GP with some concerns regarding the development of her 2.5-year-old son. This included some behavioural issues such as frequent and aggressive tantrums and communication skills, including limited use of words and not speaking in sentences. The GP referred on to their local child and family health services, requesting speech pathology and early childhood social work. And in that referral, the GP highlighted some possible concerns regarding family wellbeing, although the GP noted that there was nothing specifically mentioned by the mother during her appointment, but had a sense that perhaps there was a bit more going on than what was discussed at that appointment. So the early childhood social worker conducted an initial assessment at the family home and identified that there were limited social supports because his family had relatives overseas who were unable to come to Australia due to COVID-19 in their home country. This boy was attending childcare for 2 days per week, and the early childhood social worker attempted the domestic violence screening tool with the mother denying any domestic violence in the home. But similarly to the GP, the early childhood social worker felt there was more to the picture as the mother was frequently disclosing relationship issues alongside the behavioural concerns that she had for her son. We came to an agreement that the early childhood social worker intervention would focus on supporting the mother for managing those behavioural concerns, which I guess touches on a lot of what both Elizabeth and Natalie were talking about with regards to positive attachment and healthy relationships and the important factors that that has in those first 2,000 days. But challenges did emerge to providing that support due to COVID-19 with a shift to telehealth and the mother's partner beginning to work from home. So speech pathology then became involved as a result of that GP referral, and their assessment indicated that the child had some receptive and expressive communication delay, and they recommended a referral to the audiometry service for a hearing assessment. Both the early childhood social worker and the speech pathologist also noted a delay in play skills for this child, and recommended a referral to the community paediatrician for a developmental assessment and also to occupational therapy for additional support around play skills. The mother declined the option for this referral, citing demand of the current services she was receiving and saying she believed her child was mostly being naughty rather than having that global developmental concern. And this perspective was also reinforced by the mother's partner, who is the boy's father. The early childhood social worker and the speech pathologist continued working in partnership with mother to support the development of those communication skills and around behavioural and emotional regulation strategies. And they also scheduled a consultation with childcare. During this time, the early childhood social worker took opportunities to have some gradual domestic violence education with the mother. So then a couple of months into engaging with this family, the early childhood social worker received a text message from the mother stating that her husband had hit her, or alleging that her husband had hit her. The early childhood social worker contacted the police to undertake a welfare check, and following some of what Mandeep was just talking about, contacted the childcare provider to request information under Chapter 16A, but to also share with that childcare provider the allegations or the concerns that have been raised about the safety of the child at home. And this helped inform the early childhood social workers' completion of the mandatory reporting guide, and they ended up making a rush report. So the Department of Communities and Justice became involved and undertook an assessment, and they were able to provide some additional support before closing their involvement. And a referral was also made to the community domestic violence team. Because of COVID-19 and arrangements with the father working from home and some concerns around the safety for the mother, the early childhood social work appointments were able to occur when the mother could go out for a walk and then phone the early childhood social worker confidentially. And the intervention continued to focus on the priorities that the mother had around behavioural support for her son. Speech pathology appointments were able to be maintained via telehealth, and both the speech pathologist and the early childhood social worker were able to each reinforce the key strategies for their services and help the mother integrate that advice and support into caring for his child. And with the positive relationship that was developed between the clinicians and the mother over time, a referral was eventually made for occupational therapy around supporting play skills and a community paediatric developmental assessment. And key to this service delivery was working within the principles of partnership and tailoring services based on the needs and the vulnerabilities of this family. And that included engaging with childcare and liaising with the family GP. So I was only going to present that very briefly because I know we have our panel discussion as well, but I guess I just wanted to try and highlight what some of those aspects of health responses, child protection and child wellbeing responses might look like with some of the families that may present to your practice. Thank you.
Oh, thank you so much, so Rachel, Amanda and Mandy. That was shows you how very complex and how many people need to be involved in some of these children's lives and how important getting access to all those services is. Talking about access to services, there's one other thing I just wanted to quickly mention before we move into the panel discussion. And some of you may well have seen some of the e-referrals that have been happening for a while now, so through HealthLink. Yes, so we're in Sydney Local Health District. So we did have a slide, Lauren, I'm not sure if you've, we can pop that up, but we've actually had a number of, everyone can do the HealthLink to the Roads and Maritime, have been able to do that for some time, but the Local Health District has been certainly getting some services up we've had for a while, and more recently, we've actually very happy to say that we've actually got the Sydney Local Health District Community Paediatrics now have the e-referral. There was a slide, might come up later, or we might have to send it out later, explaining how you actually use that. And things are really expanding rapidly. So in Concord Hospital, there are going to be about 30 new services coming out next week alone. So that's something to look forward to. So getting rid of fax machines and printing out letters. And speaking with someone who didn't have a printer at work for half of yesterday, that would got to be a good thing. Okay, so there's the slide. It might be hard for everyone to take that on board today, but in best practice or in Medical Director and Genie, at least those three medical softwares, you can actually send your referrals via Health Link. So we might be able to send that slide out, Lauren, so everyone can perhaps follow that. All right, thank you so much. It's been really interesting. So don't forget, if you have any questions, pop that in the chat, and I'm going to invite our panel back on again so that we can ask some of those questions that you put in the chat. So of course we've got Elizabeth. Hello, Elizabeth, back again. Natalie, Rachel, Mandeep. We've also got Alexandra Reid, who's the nurse manager from the South East Sydney Local Health District, Child and Family Health Services, and Frances Dobson, who's the paediatric occupational therapist, is joining us as well. So we don't actually, I think we can't get everybody on screen, but thank you so much for those who were there. So thank you so much. So I'm just going to read out a couple of the questions. The first one that came through I thought was a very interesting one, Elizabeth, and I think it was sent to you, and it's about parents who would like to teach their toddler 3 languages, but they're worried that that might actually get in the way of their communication, might delay their communication. So is there any tips you could give that ways around that? That's an unusual one for you. So we're starting off an unusual question.
Yes, indeed. I think Natalie is actually better placed to answer this one than me. 3 languages is unusual, but my understanding is that there is no problem with bilingual so long as there's consistency in language as to who is saying what language. And so if one parent always speaks in one language and another in another, or grandparents speak in one language or parents or another. But I will defer to Natalie. Away you go, Natalie.
Oh, you're quite right, Liz. I mean, I suppose it sort of depends what the parents mean by teach. As you know, children learn by immersive experiences, and if they are living in a household where different languages are spoken and they don't have any inherent language problems, no problems at all. In fact, yeah, they should pick up the languages naturally. If you come from a country like myself, Malaysia, where we speak Malay, we speak English and our Chinese dialect, it's evidence that, you know, if it's immersive, if it's part of society, and, you know, the child picks up the languages naturally.
That is so interesting, and it brings to mind the graph that you put up about the effort you need to put in with the increasing age. I think I may have missed my opportunity there somewhere of learning through that.
It takes a bit longer, a lot more effort.
Yeah, I think I've missed it completely. We've also got a question around where we could find some more resources on reading about the first 2,000 days of life, and maybe that's something we could send out, some links perhaps.
Yeah, absolutely. So if you just Google New South Wales Health in the first 2,000 days, then the framework document is there. And there are a lot of references at the conclusion of that framework document. And don't be put off, it's not a normal New South Wales health policy document. It's got images, it's got, it's much more interesting. The TED talk by Nadine Burke-Harris, I think is fantastic, just that 15 minutes to explain ACE. Natalie and I have both referred to the Harvard site on the developing child, which just has a wealth of resources on brain development, the importance of that era. I've just been to the 0 to 3 conference in the US virtually at night for a week. And 0 to 3, if you haven't seen it, is a phenomenal resource with also lots of resources for parents on the importance of the early years. But we're about to launch the first 2,000 days as an intergovernment strategy, and there'll be lots more resources that come out from that. So it's really exciting because obviously, whilst this science and evidence is within health, the outcome is with our partners in education and facts and justice, and they have embraced it. So it's actually going to be an intergovernment strategy to be launched soon, which is very exciting.
That's indeed. I love the next question because it really comes around our relationship with the MBS and whether we should be controlled by the MBS. So the question is, well child checks often dovetail with vaccinations, and therefore potential gaps happen between 18 months and 4 years. So the question really is, what are your thoughts on introducing a 3-year-old NBS child health screening for GPs?
I'll start. I was involved in the wonderful Healthy Kids check of the 4-year-old one, which is no longer an MBS item. So it's at a Commonwealth government level, as a state bureaucrat, I'll say it's quite hard to get targeted MBS items. So yes, it remains a significant issue. I thought the Healthy Kids check was just fantastic and was devastated when that was removed.
Yeah.
The answer is yes.
Yes, absolutely. I think the answer from all of us is yes, but it's unlikely to come in, isn't it? I guess is the answer. And Natalie and I were talking earlier about how mums are very aligned with their antenatal checks and very, following schedules for antenatal checks, and also extremely good in those first few vaccines. So we have a high uptake in those first the 2, 4, and 6 month vaccines, and then often things that the vaccination rates sort of start dropping off as we get past 18 months, especially to 4. And we were talking about how maybe what we need to be doing is putting in recalls, not just for vaccines, but recalls for the routine child checks, and really follow the blue book as opposed to follow the vaccines for those.
That'd be wonderful.
Checks.
Absolutely.
But yes, NBS may not catch up with us, but does still. Another question for you, Elizabeth, which was the graph showing the pregnant women with stress and no medications versus I think it's depression, women taking medications and women with no stress, and the impact on the baby. How did the amount of medication and which medication the mother was taking accounted for?
Okay, so that wasn't stress. I presume that was the Danish linked data study, and that was women who had been diagnosed with clinical depression. So it was a control group. It was mothers who have clinical depression and took their medication as prescribed by their psychiatrist, and mothers who chose not to take their medication because they were concerned about the effect of the medication on the child. And the importance of that as a piece of the evidence is that a child's mental health is also developing in utero. At 0 to 3, there was the most amazing graph that just made it all, clarified it for me, because in the top row, it had the age of when mental health diagnosis is made. And as we know, 2/3 of significant mental illness is diagnosed in adolescence. And I've always thought that it was developing in adolescence without looking, as this graph did, in the middle as to when the brain's developing. So the brain is developing in the early years. And so what we're actually seeing with psychotic illness that is presenting in adolescence and early adulthood is the manifestation of what has happened in those early years. And so this is increasing evidence that is demonstrating how that is impacting on the child. And so just as we'll accept that the structure of the body is being forged in the first trimester, then the structure of the brain, and then in the first years what's happening with those connections, are also forging what might be manifest as mental illness later on. And so I guess as 0 to 3 has really blown me out of the water to understand that even more. Another very powerful graph was demonstrating of at a population level in the Dutch famine after the Second World War, massive increase, 4 times the number of schizophrenic boys manifest in their 20s. So it's all just adding to this picture of how important this precious, precious time is in these first days in utero, as well as in the first 2,000 days of life. So that slide was just one to add to that picture. And also, I think, to reassure mothers about the importance of taking their medication.
Yeah. I think that for me, that would be a great graph to show some of my mums who obviously want to do the right thing, and sometimes that feels like stopping medication. So I think that's a really reassuring thing. Exactly. There's another dreamer like me, and the question is, when will the Blue Book be fully online and integrated into my health record? I love
your question.
We're piloting that now. We're piloting it in Western Sydney and in Western New South Wales. And it's extraordinary. It's once again magic. Literally, when the GP completes their record, it goes into the consumer record, and it's real time as opposed to the other electronic records. We're just so excited. So that's the Blue Book, and even more importantly, the digital pregnancy record is being trialled in Queensland. So there's national work happening to try and get this all documented, so that it is no extra effort from a general practitioner's point of view. It just will immediately then be jointly held by the consumer, so that you can just imagine how the health literacy will increase as a result of that.
That's fantastic. And we might actually all be perhaps looking more at the ACT early signs as well, because they don't always get completed, or are delivered to us. So that might bring those to the fore, as Natalie's explained to us how important they are. So that's very exciting news. Another question, with more children attending preschool or early childhood, are early childhood teachers educated in undertaking well child checks?
That's a very good question.
Well?
There's a lot of work.
Anyone who would like to speak to that?
Sorry. Well, there's a lot of work done by Sue Wolf, and then in the Randwick campus, UNSW, in training early childhood educators to actually conduct well child checks. And I think she's got an NHMRC grant to fund these studies. It's in the horizon. I think the whole vision is to have almost a cross-agency type of surveillance strategy that's not just child and family nurses, it's GPs, it's early childhood educators, whoever's involved in the life of a child, casting eyes on them.
That's fantastic.
And just to add to that, when we changed our developmental surveillance for the personal health record, part of the reason for choosing the CDC Learn the Signs Act Early was actually it was developed for early childhood educators. And if you go onto the CDC website, they've got education, just 1 hour programs for early childhood education to learn how to do the Learn the Signs Act Early. So we wanted something that would not speak just to health, but also to the people who are seeing the children a lot more, like the educators, and also the parents. It's a great website for parents as well. Whereas the PEDS was something that was exclusively health. And we thought that developmental issues can arise anywhere. So we needed a tool that was far more universal.
Something about the village raising the child, I think we're saying, isn't it?
Exactly.
Yeah, that's right.
Yeah.
Another question around referring to the allied health services, and what's the sort of time frame for that to happen with, I guess, pre-COVID and hopefully post-COVID times? What is the sort of time frames that we would expect before we can get our children in? I don't know who would like to speak to
Sure.
that.
So it's Rachel here. I can speak on behalf of Sydney LHD. The timeframes vary depending on the age of the child. And when a referral is made, for example, to allied health, depending on the age of the child, the level of information that we receive that may or sometimes may not highlight specific vulnerabilities, we then prioritise that child and that family for services. So I can't be prescriptive around what each time frame looks like for each service, but what I would recommend is that if you are making referrals to our allied health teams, is that you provide as much information as you can, particularly where there are vulnerabilities relating to the family and the child's wellbeing. If there's information around, very briefly around the history of other children who might have also presented with concerns regarding their development, because when we have a bigger picture at that point of intake, it allows us to consult with the team leaders of each of our clinical services to look at how we might need to triage and prioritise the child for that service. So certainly for our highest priority children, across most of our services, we would be at the moment, due to COVID, be endeavouring to see them within, golly, I'm just trying to think about what our wait lists look like at the moment. we'd certainly be trying to contact the family within, say, 4 to 6 weeks. And that's partly because of, within Sydney LHD, I'm referring to us specifically, our staff have been deployed to a number of COVID-related responses across the district. So our waiting lists are looking a little bit longer at the moment, which is unfortunate. But it goes back to that point of, as much as possible, giving us the really important information about why you're concerned and why you think this family requires some of that additional support.
And this is Frances speaking from southeastern Sydney. I'm an occupational therapist, and we do have some long waiting lists for some of our services. However, children are prioritised, and obviously very young children are prioritised quite highly, and vulnerable families. But once the referral is made, the families will be contacted either by email or a phone call to be given some indication of what the wait will be, and we will also try to direct them into other services if the wait is not going to be something that meets their needs. So it's definitely still worthwhile making the referral, and we can help them to look into other services as well.
That's great. And then there was a question around if I'm not sure who to refer to, is it okay just to make a referral to, for example, the OT? Will you make an assessment and refer on to, say, a speech therapist if that's an appropriate thing, or do I need to do referrals to all of the different allied health practitioners?
Well, it would probably be worthwhile referring to everybody that you're considering, but if you're unsure, with our community health services, the best thing is to contact us directly. So we are a resource to the whole community, so not only to our clients, but to the GPs, doctors, preschools in the area, and we're always very happy to return phone calls or messages and discuss a client. The problem with, if you think there's more than one area but only refer to OT, that may miss being identified until the child actually comes in for an OT assessment. So that phone call to check out, or if you're in doubt, refer to all of the services. Often with children that are referred in for developmental issues, there are some social, emotional parenting issues as well, and there's usually not as long a wait, particularly for our younger children, for that service. So our social workers and counsellors can really get the ball rolling. The other thing would be to refer to our child and family nurses, because they are really good at deciding where to direct that referral as well, and they can get in there more easily. Alex, would that be right?
Sorry, yes, definitely, Frances. We can conduct the secondary screening, and we've got a little bit more time to do that than perhaps is available in the GP surgeries. So we can dedicate a little bit more time to the parent and the child. And then that secondary screening obviously informs where the most appropriate area is to refer that child to.
That's
and
really
I would
good.
agree for Sydney as well. Seconding what has just been said there about the importance of our child and family health nurses supporting that process. And we want to make sure that we keep our families engaged with our child and family health nurses, so that those well child checks that Natalie was talking about are completed during the course of that child's first 5 years of life. And if you're not really sure about where to make a referral to or what service, because it can be a little bit confusing if a child's presenting with a number of difficulties, outlining those functional difficulties for us. So talking about what the communication skills might be, if there's a delay in play, if there's some broader gross motor concerns and coordination concerns, that allows our intake officers to get a sort of broader picture of what is happening for that child, and they can also then discuss with you what they might recommend as part of that referral process as well.
That's fantastic. It's really reassuring. There was just another question around when would it be more appropriate to send the child to a community paediatrician for assessment? So what would trigger that rather than a referral more to an allied health practitioner? Maybe Natalie, you're the best place to for that one?
I suppose if I reflect on what we are training our GP registrars in regards to referral practices, is that if you find that there's an isolated developmental delay, then I think it makes more sense to refer to the discipline of that allied health, so speech delay, speech pathologist. But if you think that the concerns are much more broad, multiple domains, or there could be psychosocial risk factors involved, and the community pediatrician would be better placed to be I would say, the second tier assessor, who will then make the relevant referrals to, to address all the other areas as well, which includes social work. And I'm so inspired by the work that Rachel had presented about the social worker doing all that work with the mum. It's amazing.
I was amazed too, and I think the house calls by a social worker was something that I didn't realise happened. So that's amazing to know that's even available. That's extraordinary.
Yeah, so our early childhood social workers have a home visiting model of service, although that looks a little bit different at the moment with COVID.
That is amazing, isn't it? I didn't know that at all. Yeah. If anybody's, I think we're getting to the end of most of our questions, so this is the opportunity to pop another one in the question box if you want. I think there might be another one coming through, so we'll wait for that one for a second. There's just one other thing, Natalie, I think that when we were talking about when we're making sure we're updating our health pathways, again, one of those red flags was mentioning is if the child's development starts to regress. So if they're going backwards, would that be one of the red flags where I'd really be thinking of?
Yeah. I mean, regression could be a sign that the child is manifesting an inborn error of metabolism. So it's critical that they actually seek help and get referred to the right specialty soon, because the longer you wait, the more damage is done to their brain.
Right, so and
they're often genetic, and another child is on the way.
Yeah.
Yeah.
That's right. So there was another question again around accessing services, and as we know, there are a number of different ways of getting funding for some of these things that aren't done necessarily through the public system. So just a question around accessing occupational therapy via a mental health care plan. So I'm assuming that would mean seeing someone privately. Can anyone speak to that? Francis, do you know much about the accessing to OT?
Yes. Occupational therapy through a mental health care plan. So it would be for children who have some behavioural difficulties, some possible anxiety, some attention issues. Those children would qualify for the mental health plan through their GP. And that is some of the information that we can provide to people when they make a referral. We can let them know about the other ways of accessing services.
Well, that's fantastic, isn't it? Because the rebate is significantly higher than an enhanced primary care rebate.
Yeah,
so through
and that would also apply to some of the children with autism. Yeah,
fantastic. And then we're talking about the team care arrangements was the other question. So I think we've answered that. So that's through the GP management plan and the team care arrangement. But of course, there are only 5 visits to an allied health practitioner over a year. So the mental health care plan is going to be more valuable. 10 visits, I don't know, has that gone up to 20 with this increased access to psychologists? I don't know if that includes OTs as well through those mental health care plans, so maybe that's a bonus for children at the moment. I think we're coming to the end of our questions, unless anyone else wants to pop something in there.
I was just going to mention briefly that the other thing that we encourage with our younger children is to make the referral to ECI, to Lifestart.
Yes, yeah.
So that's something to really be aware of if there are any developmental delays. They're encouraging children with any developmental delay to be referred. So that's just an extra support for families as well.
Can you explain that a little bit more to us, Francis? So as a GP, do you know the process that I need to go through to do that?
Yes, so every area has an early childhood, early intervention partner. And in our area, it's Lifestart. So there's just a website. If you look up Lifestart and the referral can be made by the parents or by the clinician or by the GP with their consent, and it's they'll get through to an early childhood worker who will help them work out pathways for their child as well, so they can help them to navigate services, as well as if it looks like they are going to be eligible for NDIS, continuing along that pathway. But you do not need a diagnosis to engage with DEI.
I think that's a really critically important thing, isn't it?
Yes.
Yeah. There's an age cap, is it? Is it 6? I'm not sure.
Under
7. Yeah, it stops at 7. So, and just to, we're actually updating all of this on the health pathways, or at least the Sydney health pathways at the moment, because there has been a shift who's been the provider. So that's all just will be updated in the next little while as well. So is there anything that any of you have brought along tonight that you think we haven't mentioned, any of the panelists that you'd like to, a burning thing you'd like to say in the last couple of minutes of the webinar?
Thank you, Margot. It's Rachel here. I think there's just one point that I would really like to highlight is that given the diversity of the communities that we work with, please let us know if a family needs an interpreter, and we will make sure that when we're contacting that family for that very first appointment, that we do so with an interpreter, just to make sure that that first contact that they have with us is as smooth as possible.
That's a really good tip, and it probably is to do with all of the assessments we do as well. If we can't communicate well with the parents or the child, it's not a very valid tool, isn't it? I think there was one very last minute question. So in the last seconds, we've got, I've always find it very difficult to coordinate a team care plan for a child with just speech delay to see a speech therapist. How do I go about that if there are no, I think that means that for obviously a GP management plan, we need at least 3 people involved in the care to get that team care arrangement. So I think the question is, how would I do that if we don't have 3 health providers? I don't know if there's an answer to that one, but I think it would probably adding an extra person to the plan, or maybe they don't actually qualify for a GP management plan and team care arrangement. Unless someone else has got any other tips. No, looks like we haven't come up with a solution for that one. So anyway, I'd like to thank absolutely everybody for coming. I think it's been incredibly valuable night tonight. I've certainly learned things. Just a reminder that there are those handouts that if you, on my screen, it's up on the top right, there are the handouts there. And if there are any other resources that you need, I'm sure Lauren would be quite happy to send some of those around if you contact Lauren. And don't forget, you will be getting your feedback to do, and that's a really valuable thing for us so we can keep improving the services. And I'd also like to thank the PHN for transitioning so well to webinars. I think that it's been very successful, and with the COVID, we've been able to continue to learn. So thank you very much to the PHN as well. So thank you for coming along, and I think Lauren had a couple of words to close, I think. So that's good night from me.